Good. So I've been giving talks on oxygen and oxygen debt for nearly 15 years now. And I just recently realized that my good fate took me to this university, University of Szeged, 2 years ago. And it is important because there is some kind of link between my fate and oxygen debt in a way that this university hosted Albert Szent-Györgyi. You can pronounce it St. Georgi, but his name is Albert Szent-Györgyi. Hungarian is a funny language. So this gentleman discovered vitamin C in the 1930s, and he received a Nobel Prize for that in 1937. Now, we've got not too much to do with vitamin C, but Albert Szent-Györgyi also took part in discovering the citric cycle. He didn't receive Nobel Prize for this. He should have, but he didn't. So this is the cycle he discovered, and you can see the red bubbles there, and all the red bubbles mean oxygen. So it is important in this citric cycle, oxygen, and indeed, if you look at the lack of oxygen, then the greater, so this is our cursor, so the greater the oxygen debt, the higher the probability of death. So it is important, and we can prove that in animal experiments. Now, Albert Szent-Györgyi was a great scientist, and he also discovered and made discoveries in muscle movements. So when we do some kind of exercise, we do mobilize glucose, and we use glucose to produce ATP and to provide energy for muscle movements. Now, if you do some kind of long, slow run or slow exercise, then sugar will be metabolized into carbon dioxide and water. Now, if you do a sprint, so if you run fast or you do severe physical work, then there is no time for the glucose to be metabolized perfectly, and then lactate will be produced. Now, our critically ill patients, regardless whether they are in theater, on the ward or on the ICU, but they do this kind of sprint running, and they do produce a lot of lactate. And indeed, if you look at these studies, hospital and ICU mortality shows a significant relationship to the lactate level. So the higher the lactate, the higher the probability of dying. And it's not just the lactate level, but the lactate clearance is important as well. So the greater the lactate clearance, it is more likely that our patients will survive. However, I don't know if you did, but I do notice that quite often on the ICU, that lactate level doesn't necessarily correlate with the patient's clinical condition. And if you look at this study, it was an animal study. Animals were bled. And you can see that line meaning oxygen debt. So oxygen debt increased dramatically during bleeding. However, lactate showed some kind of effect initially, but then this was a major change in the DO2, oxygen delivery conditions, but lactate didn't budge. So we need something more easily, more rapidly acting parameter to show us that the patient is in oxygen debt. So going back to macro hemodynamics, then let's see how patients get into trouble. Now, at oxygen debt in you who are sitting in this room doesn't exist. It's not there because your circulation, your cardiorespiratory system delivers oxygen to your tissues, which is the product of cardiac output and the arterial oxygen content. It is roughly, in an average adult, like in you at the moment, it's about 1,000 milliliters of oxygen. This is delivered to your tissues. And you use roughly 250 milliliters of it. It's roughly 25–30%. So if you look at the blood gas, an arterial and the central venous blood gas, then I'm sure you agree with me that the pH is the same, the hemoglobin level is the same, and etc. All conditions, temperature is the same. So if you consume 25–30% of the delivered oxygen, and then you take a blood gas sample from a central vein or from a pulmonary artery catheter, you will see this kind of drop of 25–30%. So the SCVO2 is under physiological conditions, it's about 70–75. Now, if you do a sprint running, or in our patients, it's completely different. Because for several reasons, oxygen delivery will be reduced because of hypovolemia, myocardial dysfunction, bleeding, hypoxia. So oxygen delivery will be reduced. So this won't be 1,000 milliliters, but less. Now, our critically ill patients, they don't use about 25 to 30% of this oxygen. Why? Because they have pain, they breathe heavily, they are tachypneic, they are afraid of dying. Just take an example of a patient in myocardial infarction. So oxygen consumption, oxygen demand will be greater than under physiological conditions. And the unfortunate situation when oxygen delivery cannot fulfill oxygen demand is called shock. So you should forget all those long sentences in physiology books. This is the definition of shock. Obviously, we want to avoid that, and we want something which gives us a signal that the VO2-DO2 ratio has been altered in our patient. One of the possible parameters is central venous saturation. Now, a parameter which has a normal value can be pathophysiological either if it is high or if it is low. And this is exactly the same in the case of central venous saturation. High central venous saturation or mixed venous saturation can show pathologic conditions just as low SCVO2. And we do know that low SCVO2 is bad for us because if we treat that, we can improve survival. This is a legendary study by Manu Rivers from Detroit, and this was performed on an exigent and emergency department. And what they did was, they randomized patients in the ER, patients who were septic, and the control group received oxygen, central venous catheterization, arterial catheter, and these values were targeted for hemodynamic support. And the early goal-directed group received exactly the same treatment, but they wanted to keep the SCVO2 in that physiological range of greater than 70%. Now, patients in the early goal-directed group received significantly more fluid, and there was a 16% reduction in survival. So the message of this study is that if you take the physiological knowledge into clinical practice and you target it, then you might improve your patient's survival. There are several other studies which prove that low central venous saturation has clinical significance. One of the first one, Rupert's study, showed that those patients undergoing surgery who are at high risk, they are in a higher risk population if they have a low SCVO2. They mean value or median value was 64%. And if you wean your patients on the ICU, then again, low or decreasing mixed venous and central venous saturation can be an indicator of weaning failure. Now, in trauma patients, if you take a central venous blood gas on admission, and if it is lower than 65%, then again, these patients have higher risk for dying and prolonged hospital stay. And what you can use it for, it might be an indicator of acute bleeding or transfusion. Now, this transfusion was one of our main interests in the last couple of years, because it is very difficult to tell precisely when to transfuse patients. So one of the possibilities is to use central venous saturation. But how can we use it? There was no evidence for that, and there wasn't enough evidence. So what we did, we went to József Kasaki's laboratory in the University of Szeged, and we performed an animal experiment. We called it isovolemic anemia experiment. What we did was, we bled the animals, this is what B stands for, about 10% of their body weight, and we immediately replaced it with hydroxyether starch. So this is how we try to keep the animals isovolemic. And we allowed the animals to stabilize for 5 minutes, and then we did our measurements, hemodynamic measurements and blood gases. Now in this table, what you can see that after 5 stages of bleeding, the hemoglobin dropped dramatically. Now, if you look at the intrathoracic blood volume index, the animals remained stable. So in other words, we achieved our goal of isovolemia. Now, the cardiac index, in fact, improved despite of the drop in hemoglobin. That was due to tachycardia. I don't show the data to you. However, this increase in cardiac index couldn't compensate for the anemia-caused drop in oxygen delivery. There was a significant drop after 5 stages in oxygen delivery. And because of this, the VO2-DO2 ratio from the normal 30% went up to 44%. It increased significantly, and that was accompanied by a drop in central venous saturation. Looking at correlation between the oxygen extraction ratio and the SCVO2, there was a significant, a pretty strong, significant negative correlation. So the message of this study at this stage was that central venous saturation correlates with normal volemic anemia or isovolemic anemia. Now, there is another thing I would like you to think of when you take blood gases from your patient, and this is the central venous to arterial CO2 gap. Normally, it is less than 5 millimeters of mercury. This is the venous side, and this is the arterial side. We do have studies showing that this kind of CO2 gap, if it increases, then it is almost as good as lactate in differentiating in septic patients between survivors and non-survivors. So the message of this study is that if you find in your septic patients an increased CO2 gap, they might be at higher risk. And indeed, if you look at the kinetics of SCVO2 and lactate, they show more or less the same kinetics. So together with lactate, and they also correlate with the SOFA score in survivors and non-survivors. Now, if we go back to our isovolemic anemia model, then what we found regarding the DCO2, you can see the SCVO2 oxygen extraction correlation here. And what we found was a significant positive correlation between the CO2 gap and oxygen extraction ratio. So what this tells us that together with anemia and developing oxygen debt, the central venous saturation drops and the central venous to arterial CO2 gap increases. And if we add those two together, then to show a greater than 30% oxygen extraction ratio, if you have lower than 70% SCVO2 and the greater than 5 millimeters of mercury, this central venous to arterial CO2 gap, then you have a pretty good specificity to indicate great oxygen extraction ratio. Now, our next question was whether DCO2, the CO2 gap, shows us hypovolemia. So we went back to the lab again, and we performed another animal experiment on pigs. And what we did, we gave a bolus of 5 milligrams per kilo furosemide to pigs, and then we carried on with this kind of infusion rate to force diuresis and to make them hypovolemic. We we took measurements in 20 minutes, and we took bloods for blood gas analysis, we did hemodynamic measurements, but we also looked at the microcirculation of these animals, applying the orthogonal polarization spectroscopy, the OPS. Now, on this slide, you can see that due to the forced diuresis, the animals became hypovolemic, cardiac index, and the global end diastolic volume dropped significantly as time went by. And as an effect of this, the oxygen delivery dropped significantly, and the oxygen extraction increased significantly. So we achieved our goal of hypovolemia. Central venous saturation moved together with that pathophysiological change in the animals, dropped significantly, and the CO2 gap increased significantly. Now, looking at the correlation, again, you can see very strong negative correlation with the oxygen extraction and SCVO2, and strong positive correlation between oxygen extraction and the CO2 gap. If we take a cutoff for SCVO2 as 70% and 5 millimeters of mercury for the DCO2, then what we found that to predict greater than 30% oxygen extraction, we had a pretty good sensitivity and specificity for SCVO2, and not as good, but acceptable for DCO2. However, if we again added together the SCVO2 and the DCO2 to predict or indicate a greater than 30% oxygen extraction ratio, then we had a pretty good specificity. So the message of this, that if your patient has normal SCVO2 and low or normal CO2 gap, your patient might be safe and not be hypovolemic. Of course, it has to be confirmed by human studies. The increase in the CO2 gap can be explained by the changes in the microcirculation. We measured the perfusion rate of the microcirculation and the red blood cell velocity. And you can see that as time went by, these dropped significantly, so hypovolemia caused a significant change in the animal's microcirculation. So finally, in our critically ill patients, regardless whether they are in theater or on the ICU, everything is revolving around oxygen. Global tissue hypoxia is of utmost importance. However, we don't have a gold standard to recognize it, to measure it. Now, the two indicators I'll show to you, you are all aware of the lactate, so I don't want to waste time on that. StVO2 is less invasive and cheaper than mixed venous saturation. It's just as good to my assessment, but may not be as accurate, but it is an easy to use measure. Please use it. And the other very interesting tool, what we can use, is the central venous to arterial CO2 gap. However, there's little what we know about it, and there is still a lot to do. So any of you who is interested, please join in the work. Thank you very much for your attention.